How about primary stability? What do we do? What does it mean for a patient like this? 48-year-old healthy female, non-smoker, very high aesthetic demands, high lip line, very long, sharp papillas, thin biotype, and she has a horizontal fracture through central incisor. She is uncomfortable with this, very self-conscious, very concerned that she's going to lose this tooth because it is mobile. And you can see in the cone beam, we have some alveolar volume. There is a little bit of buccal plate. On the other hand, there's also about 1 millimeter or so of crestal bone loss on the direct facial. So once again, let's vote on this one. Do we extract and graft the socket? Do we extract and do an immediate placement with no provisional? Extract immediate placement with provisional? Or just bond the tooth, bond to the adjacent teeth and leave it alone? Stabilize it. Okay, so we're about 50% or so immediate placement and provisional, about a third no provisional, and the rest are extract. Okay, good. Well, the attitude that we've developed over the years has been pretty well laid out in this publication that these two publications that I've done with this group. That's Phil Fava, Joe Kahn, Luis Gonzaga, Harry Randell, Stephen Chen, Bob Levine, and Chris Evans. And we have these two publications in compendium, which may not get too much traction here, but it's fairly widely circulated in the US. And we call it 10 Keys to Successful Aesthetic Zone Implant Placement. And those 10 keys include immediate placement and contour management. And I'll show you a little bit how we do that. So the first part of this is atraumatic tooth extraction, although I will tell you that any tooth that's extracted on me is going to be traumatic, so we try to minimize the trauma. And just take the tooth out without disturbing the socket as much as possible. The implants tend to be placed towards the palatal. We tend to use smaller diameter implants, so no larger than approximately 4 millimeters. You can see just the osteotomy being developed towards the palatal. We want to leave a buccal gap of a couple of 2 to 3 millimeters. That same combination of autogenous bone chips plus demineralized bovine bone, which is slowly resorbing. I like to pack the socket with a guide pin in place in order to make sure we get a good fill, and but not over condense it. Implant is placed to the palatal. And then the key is we need to have good primary stability. Even though there's a lot of facial graft material in contact with this implant, it still has excellent primary stability. So with that, we're either going to fabricate a provisional restoration, or we're going to make a custom healing abutment. And you can think of this provisional as being a long or an aesthetic healing abutment. In her case, we were able to take her natural tooth, hollow it out, convert it to a provisional restoration. One of the other keys is augmenting both the soft tissue and the hard tissue. In this case, it was done with a palatal connective tissue graft. And you can see how she leaves the office looking like this. And in fact, I didn't point it out, but she had some recession on this central incisor. Now we've overcorrected that a little bit. So at 1 week post-op, it looks something like this. And at 10 weeks post-op, we've actually still maintained that overcorrection of the pre-existing recession. The radiographs look completely normal. She complained a little bit because she thought there was too much gingiva on the facial of the final restoration, so we went back and did a little laser gingivoplasty. And if you look, you can see now how high she smiles, where she shows the gingival margins of everything. And again, if you compare the pre-treatment, where we have some pre-existing recession, to the post-treatment, we have a near-perfect replacement and restoration. So I think this sort of illustrates what's possible if we follow these 10 keys, one of them being obviously maintaining that primary stability and knowing it in the first place.